this saying to apply ice locally to the injuries. Really, most rigs are not going to have actual ice. Cold packs can help them, but we want to make sure that we're treating pain if we can with some of our pain medication, right? And then for soft tissue injuries around the mouth, we're always looking for bleeding or fragments inside the mouth, and we're going to suction as appropriately. We want to maintain an open and patent airway. If you have a patient with a large avulsion or a laceration, for the most part, they have really good surgical techniques now. And if you find portions of skin that have been removed from the face, make sure that you wrap those in a sterile dressing, put them in a plastic bag, and then bring those with you to the hospital. In this picture, you can see a really significant avulsion. This patient, basically, for lack of a better way to put it, looks like they've been scalped. We want to just loosely place that avulsion back into place. Now, in the case where you had, say, significant amounts of dirt, like if somebody was ejected from a vehicle and they had a large avulsion and there was dirt from the ground, this is something, again, that you might want to grossly irrigate really quickly before you lay that back on, and you're going to just cover them up with a sterile dressing and get them to the appropriate place. In regards to scalp lacerations, these are really hard to kind of identify. Typically, most people have thick hair and they're going to mat and coagulate, and it's going to be really hard to see how large this laceration is. The scalp bleeds tremendously, so always kind of suspect that this is a larger injury than what you're going to be able to visualize. And if you can see it and you can control it with just some simple soft pressure, right? You don't actually want to hurt somebody by pushing down. And then evaluate for what caused it. I mean, if this is a small nick from a piece of glass or something like that, obviously we're going to pad that and just kind of hold our hand over it. But if this is something that may actually have had a puncture with it, remember that something may have punctured into the cranial vault and then been removed, and we actually cannot see that. So treat any of these injuries with a high index of suspicion. You can see where we're talking about how to hold pressure on an injury and then replacing the avulsions back onto the kind of approximate location. If you suspect that there's a skull fracture, again, we're not going to apply a lot of pressure to that because we don't want to create any potential for injury to the brain if it already doesn't exist. Now we're talking about injuries to the eyes. Again, looking at the eyes, we're looking at the sclera. Is it white and bright, or does it have a significant bleed in the tissue, and are we actually seeing the blood kind of move across? We're looking at pupils. Are they equal and reactive? And if they're not, and our patient's able to ask us, we always want to know historically, did they used to be equal and reactive, or is this a telltale sign that there's something happening because of the acute injury right now? In regards to injuries of the eyes, pretty typically an injured eye is from a foreign object. This could be anything from a small debris from grinding or a piece of dust or dirt. And a really small cut to the cornea can be intensely painful for a lot of people. And we want to make sure that these patients have significant irrigation with the sterile saline to kind of flush away any loose particles. Eye injuries are considered pretty high acuity in most EDs. And so you want to make sure that these people are getting into the appropriate place where they can have the correct assessment done with perhaps, say, a contrast dye. Again, we're always looking to flush this. If you're looking at this particular patient, it appears that somebody's got this set up with a nasal cannula, and they're using a nasal cannula, the two prongs on it, to actually flush both eyes. I'm not sure how they've got that set up on the normal saline bag, but I'm sure we could figure it out in the lab. Any foreign body can leave a small abrasion on the surface of the cornea or the conjunctiva, and if you use some gentle irrigation, it will not wash out those bodies stuck to the cornea or under the upper eyelid. You may be able to remove it with a moist, sterile cotton-tipped applicator, but again, unless you're fairly certain that you can get it without causing more damage, usually the best thing to do is to irrigate the eye and then cover the eye up and have them not move the eye. Make sure that you've got both eyes covered, have them lay there, be very still, and not look around or anything like that to irritate or create any more damage. If you see anything stuck in the actual cornea, we're never actually going to try to remove that. it may be impaled into that tissue, and it's going to be really difficult to kind of move it. So again, this is one of those cases where you're looking at it and you're like, I should probably just bandage the eyes and make sure that they're actually not looking around and creating any more damage. If you see a significant object impaled in the eye, we're always going to cover that eye with a moist sterile dressing. You're going to surround it with some kind of padding that's going to put a little even pressure around the eye. And then again, bandage both eyes, because if a patient has one eye that's open and looking, both eyes tend to track in the same direction. And so we want to keep them, for lack of a better way to put it, kind of blinded, because we want them to just look straight forward and keep movement to a minimum. Back to that burn of the eye, again, I'm not sure what creates this discoloration of the actual eyelids, but if it's chemical burns, we want to flush with copious amounts of water. And again, I'm saying like at least 1 liter. You guys really want to be going after this like 10 to 20 minutes or the entire duration of your transport. And as you can see in this lower picture, this eye has got significant damage. I can't really tell what the skin is actually looking like around that, but you can see there's some cloudiness to the pupil, and we can see that kind of bleeding into the sclera. More eye irrigation. Again, you can directly irrigate by pouring saline. It looks like the nasal cannula prongs are effective for bilateral eye injuries. Rinsing with a low pressure hose, or perhaps splashing or dunking that side of the face in for that one part of the eye. The key again is copious amounts of fluid for a significant amount of time to help try to remove the offending agent. Okay, so now we're going to talk about light burns. And light burns can be caused by many things. Anything from infrared lasers to people looking at eclipses and other kind of high focused energy beams. One of the more common ones that you'll probably get, and myself included, this is a personal thing that happened to me, was like a welding flash, or perhaps like I was plasma cutting or something like that, and I didn't have the proper shade of eye protection on, or quite honestly probably didn't have enough eye protection on or any eye protection on, and was using inappropriate methods to kind of block that light from the eye. This can cause some almost what we would call like a sunburn to the cornea. It's really rather painful, and it can cause some really kind of inhibited vision for several days. And if it makes its way to the retina, it will kind of not be so painful, but it may actually result in permanent damage. So severe conjunctivitis usually develops with redness and swelling, and there's a lot of tear production because it's trying to kind of soothe and remove any of the damaged tissue. And in the cases of this, you want to cover each eye with moist pads and an eye shield. And again, this is one of those things that you're going to need a physician to take a look at. In regards to penetrating eye injuries, we never want to put pressure or manipulate an injured eye, right? Like, you don't want to touch the globe. If part of the eyeball is exposed, gently apply a moist sterile dressing to prevent the drying, and then cover the injured eye with a protective shield, and then make sure that if there is an uninjured eye, it is also covered, because we do not want these patients moving or tracking their eyes, because the good eye will cause the injured eye to kind of track with it. The two are going to be connected as far as movement. Now, in the unfortunate case that you actually see an eye that has displaced itself from the socket, this is something that you absolutely do not want to put any hands on. You're just going to try to protect this with a sterile dressing. Make sure that you cover it up, and then have the patient lay still. Keep the intact or good eye completely covered so that they're not trying to move. Those small muscles are going to try to flex. This is involuntary for the most part, and we want to make sure that we're very, very diligent with the care of an injury this significant. In regards to contact lenses and artificial eyes, there's really no reason for you to get into somebody and try to take their contact lenses out unless there's some kind of chemical that may have gotten underneath the lens, as being trapped between the lens and the actual eye. And so if that's the case, like that's the only time that you're going to reach into somebody's eye and try to remove their contact lenses, there's not a lot of people that actually use, or I should say utilize, hard contact lenses anymore with modern technology. But if you actually need to remove those, it's saying to use a small suction cup. I'm not sure that anybody has that in the back of the rig. but your patient may be able to help you actually remove that themselves. On a soft contact lens, you can generally just kind of wet the eye a little bit with some saline, and you can use a fingertip or two to kind of move the lens out of place and get it pinched between your fingers and move it and lift it off the eye. In those rare cases that you run into somebody who has, say, an artificial eye, the telltale signs for that is that they don't quite appear to look exactly the same. The iris and the cornea are going to have kind of a different appearance to them. And because that actual artificial eye is not connected to the muscle in the orbit, it's not going to move with the uninjured eye at that point, and it's obviously not going to respond to any kind of light source. Now we're going to move over to the injuries of the nose, and again, the term for a nosebleed is epistaxis. And unfortunately, one of the most common causes of epistaxis is digital trauma, which means that there was a finger in the nasal cavity or in one of the nares. Anterior nosebleeds usually originate from the area of the septum, and they bleed slowly. Posterior nosebleeds are usually more severe, and they often cause blood to drain into the throat. Either way, as we said in previous lectures and just previously in this lecture, this is something that we just want to use some light pinching pressure against the actual cartilage of the nose, and we're going to try to allow that blood to coagulate and cause pressure against the capillary beds that are actually bleeding to help it clot itself off. The biggest take-home point on anybody with a nosebleed is to absolutely try to coach your patient into not sucking the clot out. If they have coagulation in the sinus cavity, it's going to be uncomfortable. They're going to feel pressure, and their biggest reaction is going to want to be to suck that back so they can spit it out. And every time they do that, they just kind of tear the clot away and it continues to bleed. So you have two forms of action here, which is one, create a place for that blood to pool so it will coagulate and actually create that kind of clot. And then two, don't allow them to suck it out and actually spit out that clot, because they're just going to tear it away and continue to bleed. This is a pretty good diagram of where the sinuses are in the nasal cavity. If you're looking at the side view here, you can see, like we teach in lab, the actual nasal passage, the nasopharynx, is a flat floor on the bottom, and this is why we teach you to use an NPA to not arc it up towards the eyes when you're trying to place this. We just want to run straight back from the hard palate to the soft palate. You can see that there's folds of tissue there, and these are called the turbinates. The turbinates have copious amounts of capillary beds because we're using this sinus cavity to predominantly warm and moisten that air as we're breathing. If you have a significant head injury, you could have a cranial fracture at the base of the skull, which may allow CSF to actually leak from the cranial vault into the sinus passages. And this is actually pretty tough to actually diagnose in the field, but it should just be a pretty high index of suspicion based on the actual injury pattern. Again, if you suspect that somebody has that kind of an injury, they are no longer a candidate for an NPA. We actually do not want to risk trying to penetrate into the cranial vault with any kind of foreign body. And if they're bleeding from the nose, we're going to gently pinch the nares together, and we're going to allow that to kind of build up some pressure, and it's going to help to kind of clot that off. Always coaching them to not try to clear it and then spit it out. Now, if we're talking about ears, ears typically do not bleed very much because there's not significant amounts of vasculature that's in the ear. If you guys are thinking about the external ear, that is mostly cartilage with a light amount of skin around it. And so they're not going to bleed a whole lot, but they look pretty significant. And then we're always concerned about the inner ear damage in this. So again, this is something that you just may want to kind of control bleeding if you can. And then you may put some kind of padding to kind of help locate the ear to the face, like in an approximate location. We're not going to try to replace it or put pressure on it to help control it. At that point, we're just stabilizing the tissue. Again, in the case of a complete avulsion, right, or we've lost a portion of the ear. We want to make sure that we can locate it if it's at all possible. You may want to rinse it off with a gross decontamination of normal saline. You're going to put it in a sterile dressing and then put it in a plastic bag. We're going to take this with us for hopefully to have that reattached. Foreign bodies that are stuck in pieces of avulsed tissue should be removed by a physician and not by you. Any clear fluid coming out of the ear may be CSF, and you should suspect that there's some kind of skull fracture at the basal portion of the skull. In the case of a facial fracture, as this slide is saying, it's not an acute emergency unless there's serious bleeding. Now, in this particular person's case, I would say that that's a pretty significant facial injury, and that was an emergency. The bigger danger is blood clots forming, and what it's saying here is plastic surgeons can repair the damage if it's treated within 7 to 10 days, and that's before the bone resets in an improper place and would actually need to be refractured. So the bigger problems are going to be the swelling, obviously, obstructing the airway, and so that's the primary thing that we're looking for is a patient who has significant swelling. We need to be on top of maintaining their airway, and that, again, depending on the particular area damaged in the face and what our capabilities are, may be a supraglottic airway, or you may need an ALS intercept because that may become a crike airway. In regards to dental injuries, this is usually as a result of something traumatic, and it can be emotionally traumatic to a patient because most people value their teeth. Bleeding will almost always occur when a tooth is actually displaced out of its socket. If it's just fractured, that typically will not bleed. It's just going to be really, really painful. And if you have something that's bleeding, like the actual root of the tooth has left the jaw, we want to make sure that we're giving them some kind of gauze to kind of pack it up against the actual opening or cavity to stop the bleeding, because we don't want blood entering the airway, and then we're going to maintain a patent airway. This is one of those cases where if they're bleeding significantly and you can't stop it with a little bit of gauze in the mouth, you want to perhaps give them the suction device and teach them how to use it so that they can suction their own airway and they can maintain themselves. So if you can find a tooth that has been traumatically avulsed or knocked out and it's got a complete root with it, you can actually take this and put it in some sterile saline, and then you can transport the tooth back with the patient. And if you can get them to the receiving facility where they can have some physician look at this, the tooth may be reimplanted, and if it's supported, it can actually basically reattach itself back into the jaw. Now, while we're talking about injuries of the cheek, you may encounter a person who has an object impaled into the patient's cheek, and this is not something that we actually want to try to remove ourselves. And remember, if you have something that maybe perhaps was had entered the cheek and then been removed, like if this was a violent assault or something like that, they may have a communicating injury, which means that the exterior of the face and to the interior of the mouth are now able to communicate air. These patients can actually aerosolize blood, so you want to make sure that you're covering this kind of wound up with some sterile gauze or some kind of bandage, and then we want to make sure that we are not occluding the mouth, but we absolutely want to support any tissue or anything like that. And if the patient actually still has the offending agent, like it's impaled into the cheek, we're going to try to secure that and support it so that it does not create further damage. Getting into injuries of the neck, we're going to talk about the upper airway, the esophagus, the carotid arteries, and the jugular veins, and then the thyroid cartilage, which is the Adam's apple, and the cricoid cartilage in the upper part of the trachea. Any blunt trauma to these upper airway structures can cause significant swelling and actually cause your patient to lose a patent airway. This can be a significant and very much life-threatening injury. If we have any kind of crushing injury to the upper part of the neck, it's very likely to involve the larynx or the trachea, and once those cartilages are fractured, they do not actually go back to their normal position. This is something where they will have a tracheal deformity, and it can become extremely detrimental to maintaining a patent airway. Now, if that trauma is significant enough, The patient can lose their voice because of the swelling or damage to the actual trachea where the vocal cords are going to sit. They're going to have difficulty swallowing because of the muscles and the small bones that are located in the neck. And sometimes these can become pretty much a fatal airway obstruction. If there's any kind of actual fracture that's going to allow air to escape through the trachea underneath the skin, this will cause what we call subcutaneous emphysema. And this is as you palpate somebody, you will kind of feel, the easiest way to kind of think about this is it feels like Rice Krispies kind of crackling underneath your fingertips as you're palpating along the neck. If you feel any of that, you know that you have a pretty significant airway problem and that we need to be en route to the right facility. All right, so now we're looking at somebody who obviously has an impaled object in her neck. This looks like it was perhaps something of a violent situation. If you were to happen on this particular patient and they're actually still viable, this is not to be taken lightly, because if you're looking directly at her neck, you can see that this has basically landed a little midline of the sternocleidomastoid, and we know that the big structures right there are going to be the carotid body and the jugular veins. We're never going to remove this object, which may actually be the only thing keeping it from bleeding, but we have to suspect that she's bleeding internally, either into the throat, or the esophagus or the trachea, or just into the thoracic cavity, as well as we're looking for some way to kind of stabilize her neck to make sure that we're not creating an additional issue if it's anywhere along the cervical vertebra. All right, so that's the end of this lecture. Again, facial and neck injuries should not be treated lightly. Things that appear to be very insignificant in nature can have severe consequences if we miss them, and sometimes we get caught with something that looks significant actually being fairly minor. So it's best to err on the side of caution. Always treat anybody with a facial or a neck injury as a potential lethal injury, and we want to make sure that we get these patients to definitive care.